Welcome to the short section on adrenal incidentalomas. Why adrenal incidentalomas are important? Because as the name suggests, this is a tumor or this is a lesion on the adrenal gland which was detected incidentally, which means you have done a CT or an MRI scan for some other reason and you have accidentally picked up a adrenal lesion. And the patient is not having any clinical features due to the adrenal lesion. And you have to answer many questions here. So whether this tumor is hormonally active, that is functioning or not, whether this tumor is benign or malignant, what will be the course of the tumor in the future, whether you will follow up this tumor or you will stop the follow-up. So a lot of questions you have to answer, which means the main assessment will be based on the hormonal assessment to find out whether it's functioning or not. And most of the assessment will be based on the radiological assessment. You need a lot of help from the radiologist as well. So let us go and start discussing the adrenal incidentalomas. Especially we have to know the etiologies of the adrenal incidentalomas first. What are the etiologies? So I'm going to construct a 2x2 table where I'm going to write non-functioning tumors on one side and a functioning tumor on the other side. Similarly, I can categorize into malignant tumors and benign tumors. So I can write benign tumors on the top, which are fairly common, and malignant tumors on the bottom, which are fairly uncommon but still contribute to a sizable number. Whether functioning or non-functioning, which is common, non-functioning tumors are more common than functioning tumors. Almost 85% of the adrenal incidentalomas or any adrenal tumors are non-functioning. Only 15% of the adrenal tumors are functioning tumors. Similarly, majority of the adrenal tumors are benign and majority of them will be non-functioning as well. And among the functioning tumors, most common hormone hypersecretion will be cortisol. So most of them will be cortisol secreting tumors only. So let us start the etiologies. Number one, the most common will be an adrenocortical adenoma. That will be the most common. It's called benign adrenocortical adenoma, which contributes to 60 to 85% of the overall adrenal tumor list, which means this is going to be the overall most common, at the same time most common among the non-functioning tumors, at the same time most common among the benign tumor lists also. Or it could be a myelolipoma, which is radiologically a classic lesion, which will be showing a macroscopic fat, which is very easy to pick up. Or it could be an adrenal gland cyst, or it could be a hemorrhage in the adrenal gland. The details of adrenal gland hemorrhage and its etiology we have already discussed in the adrenal insufficiency chapter. Similarly, it could be some infectious cause like a granulomatous infection, like a tuberculosis, or it could be some fungal infection, or conditions like ganglioneuroma. These are rare tumors but still can happen, or it could be adrenal hemangioma. Not a complete list, but still, these are the usual tumors that we encounter in our practice. What are going to be the malignant but non-functioning tumors? Malignant non-functioning tumors, usually it could be a adrenocortical carcinoma, but very rare to be non-functional, but still you should not rule out the possibility. Adrenocortical carcinoma is called as ACC. Usually the tumors will be very large, heterogeneous, more than 6 centimeters generally, and they'll have this punctate type of calcifications. And most of them will be functional. They will be secreting multiple different hormones, which I told you already in the Cushing syndrome chapter. Or it could be a neuroblastoma, which is a pediatric tumor typically, may be functional or may be non-functional. Very commonly, it can be a metastasis. Metastasis, you know where it's going to originate from, very commonly from the lung, followed by the breast, even though theoretically lung is the commonest site from where your metastasis originate from. But the percentage wise, if you see, lung is contributing to 39% of adrenal mets and breast is contributing to 33% of the adrenal mets. So which means not much difference, but still for theoretical reasons for the exam, lung is more common compared to the breast. Or it could be a other very rare tumors like lymphomas. It could be a primary adrenal lymphoma, which is very, very rare, or it could be a lymphomatous infiltration by a systemic lymphoma like a non-Hodgkin lymphoma or Hodgkin lymphoma, which is even more rarer. Functioning tumors. Functioning tumors, once again, are classic adrenocortical adenoma, tends to be common Adrenocortical adenoma can be lipid-rich or lipid-poor. Lipid-rich adrenocortical adenomas are fairly more common than lipid-poor adrenocortical adenomas, which we'll be discussing subsequently, because lipid-rich adenomas are common and they typically have a Hounsfield unit of less than 10 in the unenhanced CT or a non-contrast CT. So what is the hormone that they are commonly going to produce? Usually there will be a cortisol producing adenoma only. That will be the commonest. 10% of the tumors out of 15% will be cortisol producing, even though they don't have any clinical features, a subclinical one. Or they could be aldosterone producing, which are not that common, relatively uncommon. Or you can have a pheochromocytoma, because pheochromocytomas mostly they are functional. 90 to 95% are functional. We know that rule of 10% only are non-functional, 90% are functional. Pheochromocytomas, functional but benign, catecholamine secreting tumor. Or it could be a micro or a macronodular hyperplasia. Micro or a macronodular hyperplasia, the details of which we have already studied. Similarly, this micro and macronodular hyperplasia itself can be cortisol producing, where we have discussed extensively in the Cushing syndrome chapter what are the cause of micronodular hyperplasia as well as what are the cause of macronodular hyperplasia, the receptor level defects that are going to result in these conditions. Or it could be aldosterone producing also, which is also highly possible, even though cortisol producing micro and macronodular hyperplasias are quite common. Similarly, malignant lesions. Malignant lesions, very importantly, adrenal cancer, that is adrenocortical carcinoma, I can simply write as ACC, or it could be a pheochromocytoma, which can be, yes, malignant. We have seen already what are the features of malignant pheochromocytoma. We have discussed extensively in the pheoparaganglioma section itself. So I have constructed 2x2 table where I have told what are the most common lesions. If they ask you most common overall lesion, answer should be a benign adrenocortical adenoma. If they ask you most common functioning lesion, again answer will be benign adrenocortical adenoma. The most common hormone that will be hypersecreted in adrenal incidentoloma is cortisol producing, contributing to 8 to 10% of the cases. And the most common non-functioning tumor is also benign adrenocortical adenoma only. Alright. So what will be the radiological differences between a benign lesion and a malignant lesion? This is fairly important for exams. Benign lesion and a malignant lesion. First, starting from the size of the tumor, less than 4 cm size, likely to be benign. Not always, but likely to be benign. Any tumor that is more than 4 to 6 cm in size is likely to be malignant, especially if it is more than 6 cm in size. Almost 97% of the tumors will be malignant in nature. Second, you have to see the CT attenuation in non-contrast zone. So NCCT attenuation, or I can tell unenhanced CT attenuation. We have to tell it in the value of Hounsfield units. Usually benign lesions will have less than 10 Hounsfield units, whereas malignant lesions tend to have a more than 10 Hounsfield units, which means they tend to have a higher density compared to benign lesions. Third one, you have to see the contrast washout. So I can tell 3 definitions. One is the absolute contrast washout at 15 minutes. Second one is the relative contrast washout at 15 minutes. Both are seen at 15 minutes. Or I can tell overall washout at 10 minutes. So 3 definitions I am going to give. Benign lesions usually will have an absolute contrast washout of more than 60%, which means they have an early washout, that's what I mean. And relative contrast washout of more than 40% in 15 minutes. And overall contrast washout will be more than 50% at 10 minutes. In contrast, the malignant lesions will have a little delayed washout. For example, the absolute washout at 15 minutes will be less than 60%, and the relative washout at 15 minutes will be less than 40%, and the overall washout at 10 minutes will be less than 50%. How will you find out the absolute and relative washout? There is a formula. You have to use the Hounsfield units at different phases of enhancement, like Hounsfield unit in portal venous phase minus Hounsfield unit in the delayed phase, divided by Hounsfield units in the portal venous phase minus Hounsfield unit in the non-contrast CT multiplied by 100. So this will give you the percentage absolute washout. And relative washout you can find out by using Hounsfield unit in the portal venous phase minus Hounsfield unit in the delayed phase divided by Hounsfield unit in the portal venous phase multiplied by 100. So this will give the relative washout. Fine. Whether the tumor is having lipid-rich content or not. So lipid-rich content, which means the word I use lipid means I have to assess it by MRI only. So lipid-rich content in MRI is there or not? Yes, if it's a benign lesion. No, if it's a malignant lesion. Because higher lipid is a characteristic feature of a benign lesion. That is the reason why in non-contrast CT and unenhanced CT, your Hounsfield units are low, less than 10. It's a less dense tumor. If the lipid contents are less and other solid components are more, then it's likely to be malignant. Then that is the reason why in a malignant lesion, the CT Hounsfield unit in non-contrast CT is actually high. You have to see whether the tumor is FDG PET avid or not, which means whether they take up this fluorodeoxyglucose avidly or not. No for a benign lesion, yes for a malignant lesion, because malignant lesions actually run by something called an aerobic glycolysis, which means they don't run the Krebs cycle that efficiently and they totally depend on glycolysis. So there are a lot of reasons for that. We have a lot of hypotheses for that, and one scientist actually received a Nobel Prize for the same, for discovering this aerobic glycolysis. We'll be discussing more of that in the oncology. But anyways, malignant lesions are characterized by increased FDG PET intake. And what will be the morphology of the lesions? Usually benign lesions will be regular, homogeneous, and they generally tend to have no necrosis and calcifications. Whereas malignant lesions tend to be large, irregular, heterogeneous, and they tend to have necrosis and calcification. This calcification has to be taken with a pinch of salt, which means calcifications can be benign also, calcifications can be malignant also. But in general, in exam, presence of calcifications unilaterally take it as malignant unless proved otherwise. But it can be benign or malignant. What are the type of calcification that suggest it's a benign calcification, especially if it is bilateral and more of a curvilinear or septal, rounded, coarse calcifications tend to be more benign in nature. Whereas unilateral, punctate type of calcifications, especially dystrophic type of calcifications and irregular calcifications tend to be more malignant in nature. But anyways, in exam, unless proved otherwise, calcification should obviously tell you that it's probably a malignant lesion. And similarly, we can assess the rate of growth because many adrenal incidentalomas will be followed up over a period of time. So where you can assess the rate of growth, but usually benign lesions are characterized by a slow growth that is less than 1 centimeter per year. Malignant lesions are characterized by a faster growth of more than 1 centimeter per year. So having known about the differences between benign and malignant lesions, now let us go for the approach of an adrenal incidentoloma. And we have a very good algorithm for how to evaluate and manage an adrenal incidentoloma. So when the patient is having an adrenal incidentoloma in a CT or a MRI scan, the next step is to see the biochemistry, which means hormonal assessment is pretty important and fairly important in this setting. So whether we have to find out it's a functional tumor or a non-functional tumor, that is more important. So in this regards, the guidelines tell all the patients should receive 1 milligram overnight dexamethasone suppression test because the most common hormonal hypersecretion by adrenal incidentoloma will be cortisol. So even though majority are non-functional, but among the functional, the most common will be cortisol hypersecretion. That is the reason why all the patients should receive this 1 milligram ODST, and majority of the patients with cortisol hypersecretion and incidentoloma may not have any clinical features, which means it's a subclinical Cushing syndrome that will be going on in them. So all these patients should receive this 1 milligram ODST test. Alternatively, you can do a 24-hour urinary free cortisol, but the guidelines are against using the 24-hour urinary free cortisol except a few of the guidelines. But in general, let us go with the usual guidelines, Western guidelines, which says 1 milligram ODST as the standard. Optionally, you can add a DHAS, even though Western guidelines tell definitely you have to add a DHAS. But this addition of DHAS for diagnosis of Cushing syndrome is mandatory, especially if the tumor size is more than 4 centimeter. The tumor size is less than 4 centimeter, yes, still you have to do, but more than 4 cm, definitely you have to do DHAs, because it could be an adrenal cancer which is secreting more of androgens as well. All the intermediates will be hypersecreted in a cancer. That's what you have to know. And there are some optional investigations are there. For example, if the patient is having hypokalemia and hypertension, in this setting you can do a aldosterone-renin ratio, where you will be taking plasma renin activity and plasma aldosterone concentration and taking a ratio, because this could be potentially aldosterone secreting adenoma, for example a Conn syndrome. Fine. Or for patients who are having a unenhanced CT density of more than 10 Hounsfield units, for all the patients you have to do a 24-hour urinary fractionated metanephrines and catecholamines, or you can even do a plasma fractionated metanephrines. Plasma fractionated metanephrines. As I told you previously, among the functioning incidentalomas, 10% of the tumors tend to be pheochromocytomas. Still, I am not contradicting my statement that the most common type of functioning incidentaloma is cortisol producing adenoma only. But 10%, a small number, can be pheochromocytoma. Especially if the non-contrast CT density of the tumor is more than 10 Hounsfield units, you have to definitely do a metanephrine test. So now the results can be compiled as biochemistry positive or biochemistry negative, which means there is some evidence of hormonal hypersecretion in the screening test, or there is no evidence. If there is evidence of hormonal hypersecretion in the screening test, obviously you have to follow up with the confirmatory testing, which is also biochemical testing. For instance, if you find out cortisol excess, you have to do a low-dose dexamethasone suppression test and probably an ACTH. If ACTH is low, definitely localize the lesion to the adrenal gland, so it confirms. Similarly, for aldosterone secreting adenoma, you can do a salt suppression test, which also confirms. So the confirmatory test can be positive or confirmatory test can be negative. If confirmatory test is positive, then it confirms that it's a functioning tumor, but you have detected incidentally. So in this setting, the patient is saved anyway, so you can go for a unilateral adrenalectomy. The lesion is detected much early. Happy for the patient. So unilateral adrenalectomy, you remove the tumor. If the patient is not showing any positive biochemistry, which means at the screening test itself they are negative, or confirmatory test is showing negative, then in this setting, you have to rule out a malignancy, so you have to see the radiological characteristics in this setting. So what are the radiological characteristics that will be looking out? So obviously I'll be looking out at density and I'll be looking out at the washout. So if the NCCT density of the tumor is less than 10 Hounsfield units and my contrast washout, my overall contrast washout is more than 50% at 10 minutes, it's likely to be a benign lesion, as I told you previously. So if these features are there or if these features are not there. If these features are there, it's very likely to be a benign lesion. So what are the benign lesions that you'll be considering? Number one, obviously it's a myelolipoma, very common in the adrenal gland. The clear-cut evidence of a myelolipoma will be the macroscopic fat that you'll be seeing. Let us see an example image of a myelolipoma which is going to show a macroscopic fat. This is a clear-cut and characteristic example where a non-contrast CT is showing areas of fat, macroscopic fat within them, and similarly MRI is the best modality for delineating fat, where you can see an area of macroscopic fat here. So this clearly tells you it's likely to be a myelolipoma, or it could be a cyst which is very commonly going to have a water density, which means it will have a very low Hounsfield unit water density, or it could be a benign calcification. So as I told you, benign calcifications will be usually bilateral, or even if it is unilateral, it will be usually rounded in nature and more curvilinear or septal in nature. So this is an example of a benign calcification which is more rounded. Here you are seeing a benign calcification on the right adrenal gland, which is more rounded, and it is not looking punctate or irregular. So it is very regular in shape. So this is likely to be a benign calcification, but still you have to confirm. Or it could be a hemorrhage. Hemorrhage will have more CD density, like for example, it might be having 20 to 30 density because it's blood, but very important characteristic feature of an hemorrhage is it will not enhance. It will not enhance at all. Usually tumors will enhance, but this will not enhance at all. That's a very characteristic feature. Similarly, it could be a benign adrenocortical adenoma. Usually, we have a lipid-rich adenoma. This is the commonest form. 65 to 70% of the benign adrenocortical adenomas are lipid-rich. 20 to 30% can be lipid-poor. Usually, these lipid-rich adenomas are the ones will have a NCCT density of less than 10 Hounsfield units. But lipid-poor adenomas can have CT density of more than 10 Hounsfield units. But lipid-rich adenomas will have a CT density of less than 10 Hounsfield units in non-contrast CT. Plus, at the same time, they'll be having more than 50% washout at 10 minutes. I'm going to show an example of a lipid-rich adenoma, where if you measure the NCCT density at the adenoma point, it will be less than 10 Hounsfield units. In this case, it is minus 5 Hounsfield units. So if this is the case, so which means it's a clear-cut benign lesion, or if it's an adrenocortical adenoma, so then what is the next step? So it's a clear-cut benign feature. So what will be seen? So you have to do a follow-up imaging, that is repeat imaging in this case at 12 months, especially if it's a adrenocortical adenoma. Plus you have to do hormonal assessment, the most common being cortisol producing tumor. So you have to do a DHAS and 1 milligram ODST every year for at least 4 years. So now you have to compile the results again. You have to see whether they are progressing or they are non-progressing. So there are definitions for what do you mean by progression. Progression means if the overall growth is beyond 4 centimeter, which means overall size of the tumor has grown beyond 4 centimeter, which is a sign of malignancy. Or if the growth velocity is more than 1 centimeter per year, which is again a sign of malignancy. Or if the tumor has developed some hormonal autonomy, which means the screening test like ODST or DHAS has become positive. So in this setting, it's better to go for unilateral adrenalectomy and send the sample for histopathological examination to rule out a malignancy. If it's non-progressing, which means the patient is progression-free for a period of 4 years. At 4 years, if the patient is progression-free, then there is no need for further follow-up, which means they are unlikely to develop any hormonal autonomy anymore from this point of time. So after 4 years, there is no need for any further follow-up. But what if the tumor is not showing any benign features on radiology, which means its unenhanced density is more than 10 Hounsfield units, or if the tumor is showing a delayed washout, like less than 50% washout at 10 minutes. So these lesions will be termed as indeterminate lesions or suspicious lesions for malignancy. So now you can decide based on the size, even though the guidelines differ widely in this heading. So see the size, whether it is 1 to 4 centimeter in size or more than or equal to 4 centimeter in size. So more than or equal to 4 centimeter, high probability for malignancy. So only one thing you have to see, whether the patient is having any cancer history or not, previous cancer history or not, like a breast cancer, very commonly you have to ask, or a liver cancer. If the patient is having a cancer history, then very likely it will be a metastatic deposit, so you can go for a biopsy. This is one indication where you do a biopsy from the adrenal gland. If the patient is not having any cancer history, in this setting, it's better to do a resection of the tumor in the form of a unilateral adrenalectomy and then send for histopathology examination. It can be a adrenal cancer also. It could be a benign tumor also. Doesn't matter. So this is what you have to do. If the tumor is, on the other hand, 1 to 4 centimeter, so indeterminate but not very big size, 1 to 4 centimeter. So now I will be seeing the washout. If the washout is more than 50%, or if the washout is less than 50%. If the washout is more than 50%, it's likely to be a lipid poor adenoma. So, but still it's a benign adenoma, likely to be a benign adenoma only, but it's a lipid poor adenoma. That is why in NCCT, it had a more than 10 ounce per unit density because it doesn't have that much lipid. So, it is looking more dense, but it's showing a good washout. More than 50% at 10 minutes means it's likely to be a lipid poor adenoma. So, in this setting, it's better to do a short-term follow-up at 6 to 12 months. It's better to do a short-term follow-up at 6 to 12 months. Similarly, if the lesion is not showing a good washout, which means less than 50% at 10 minutes, still there could be a chance of malignancy. So in this condition, it's better to rule out certain possibilities like a pheochromocytoma, adenocortical cancer, or it could be a METS, or still certain lipid poor adenomas can have a poor washout. So there are multiple differential diagnoses here. So in this setting, once again, see the cancer history. If the patient is having a cancer history, this patient is likely to be suffering from a metastatic deposit. So it's better to go for a biopsy of this lesion. If the patient is not having any cancer history, prior history of cancer is not there. In this setting, you don't know what is happening here. It could be a pheochromocytoma, it could be an adenocortical cancer, or even it could be a benign but lipid poor adenoma. So in this setting, it's better to do resection. There are multiple options. Are there again guidelines break down here? There are no uniform guidelines. You can do a resection, or I can do a very short follow-up within 3 months. Clear? So based on the follow-up, whether the tumor is growing rapidly or the tumor is showing different characteristics, I can do resection again. So it depends. So either you can do one thing, you can do a very short-term follow-up, or you can do a resection under this setting also. I'll just sign it off with adenocortical cancer and how it's going to look like. So this is an example of adenocortical cancer where you are seeing a right adenocortical cancer, which is very, very large. Any tumor size more than 4 to 6 centimeters is likely to be a malignant lesion. And especially if it's more than 6 centimeters, 97% chance of being malignant. So be very clear about that. It will be very large, heterogeneous. You can see a lot of areas are having different densities, and definitely many areas in NCCT will be having higher dense regions like more than 10 ounce per units. You might be seeing areas of calcifications, which will be more punctate and irregular in nature, and you might see areas of hemorrhage and necrosis. So there is a separate TNM staging for adrenal cancer as well. So this is how an adrenal cancer is going to look like. Usually be a very, very large lesion, and they will be usually presenting with abdominal pain, very non-specific abdominal pain most of the time. You might not be knowing, and they will have other characteristic phases of cancers like weight loss and anorexia and malaise as well. So I think this is a very short and sweet topic. We have completed in detail about the characteristic features of different adrenal incidentalomas and how to evaluate an adrenal incidentaloma. With this, I am signing off with this topic. In the next topic, we'll be discussing on hyper and hypoaldosteronism.